Okay, surgery 7.
Surgery 6 was so bad. He had like 18 mistakes.
6 was very tough. I
Yeah.
think that
I'm
I have done lots more more mistakes than you.
like, well, you know what? You should try to take. I took the free 120, the 2019, the really old one. You
Yes.
should try that one. It's gonna make you feel so much better by yourself. It was so easy. It was so like I was like, oh my god, I'm ready to take the step two like tomorrow. Like I wish the step two was like just like that. Like it was
Uh,
so easy.
but my problem is when I found the easy question, I do mistakes.
No, I'm telling you, take it. You're gonna see. You're gonna feel so good about it. You're gonna be like, oh my god, I'm ready for this exam. Like I took it, I was like, oh, that's so nice.
Okay, I will. We have planned to solve the free 120, isn't it? Along with
Yeah,
the NBME 14.
the 14.
Okay. A 42-year-old, this cannot be highlightable.
No.
A 42-year-old woman has the onset of chills 2 hours after transfusion of 2 units of packed red cell. She has 1 week history of fatigue, shortness of breath with exertion. Hemoglobin, her hemoglobin concentration prior to the transfusion is 8.2. Temperature is 101. The remainder of the examination shows no abnormality. Her hemoglobin concentration is now 10. Which of the following is the most likely explanation of this patient's fever?
Ready?
Ready? Yes.
Yeah. Release of cytokines from the transfused blood. The release of cytokines from transfused blood most likely cause of this patient fever following transfusion of packed red blood cells. So transfusion reactions are common and can range in severity from mild discomfort like itching, fever, rash, to life-threatening like hemolysis and anaphylaxis. The time course of this patient fever, like several hours after the start of transfusion, and normal labs are consistent with acute febrile non-hemolytic transfusion reaction, which is the most common type of transfusion reaction. Uh, the acute febrile non-hemolytic occurs because of the presence of preformed antibodies on donor leukocyte antigen and from cytokines in the plasma component of the transfused sample. It's typically mild in severity and resolves with supportive care. If symptoms occur during transfusion, it should be paused to rule out ABL incompatibility, antipyretics, and consideration of other causes of fever are recommended. Recurrent FNHTR can be prevented through transfusion of leukodepleted red blood cells. It's not bacterial contamination of the transfused blood is uncommon, but all potential causes of fever should be evaluated. Bacterial infection is more common after transfusion of platelets. Bacterial infection as a cause of fever will generally occur later than 2 hours after the start of transfusion. It is not IgA deficiency can lead to anaphylaxis secondary to perform antibodies against donor IgA and can be prevented by washing out as much plasma as possible from the donor red blood cells. This patient does not have signs of anaphylaxis. Okay, next.
12 hours after admission. 12 hours after admission to the hospital for evaluation of a right lower quadrant abdominal mass. A 77-year-old woman has dyspnea. On admission, hemoglobin is 6. Hemoglobin was 6. CT scan of the abdomen showed 10 centimeter complex mass of the cecum. The stool was brown, tested positive. The stool was brown, tested positive for occult blood. She has received She has received 3 units of packed red cell since admission. Pulse 120 per minute, respiration 20 per minute, blood pressure 130 by 90 millimeter mercury. Pulse oximetry on 2 liter per minute of oxygen via nasal cannula shows oxygen saturation 92%. Crackles are heard bilaterally. Abdominal examination shows no tenderness. ECG shows sinus tiger. Which of the following is most likely to confirm the cause of patient's respiratory distress?
Mm,
Is it
between.
B, pulmonary embolism?
Oh, I thought it was taco. Oh no, it's not. Okay,
Transfusion associated circulatory overload can be after
transfusion.
2 liter
No, not the taco. The
tra-
long one.
circulatory overload, transfusion associated circulatory overload, isn't it?
No, there is another one that's the taco and
Taco
then
and trolley. You are talking
yeah,
about that taco and trolley.
the trolley one is a longer. I don't know. I forgot what was the name. The trolley. I don't know. So
Why
you think
sinus?
it's
My confusion is sinus tachycardia because
sinus?
if taco trolley, there may be crackles. Uh, I
Mm-hmm.
know that, but
Mm-hmm.
is it sinus tachycardia happens in that
Taco and
things?
trolley. Oh, trolley.
In pulmonary embolism, one of the clinical feature is sinus tach.
Hmm.
I'm thinking on that way. Maybe you are right,
I'm
but
right,
it,
but I don't know what
but
what
it,
answer.
but
Uh,
but in tracheotomy we do not need anything to confirm the diagnosis. We
oh,
can
you
just
don't
give,
need that to say.
isn't
Okay.
it?
I, I don't know. Okay, which one is most likely to confirm them? Maybe I don't know. Okay, I'll just pick one. Let's see. That this one is confusing. Okay, X-ray of the chest. Then it's probably the taco and tradi. Okay, it's taco.
You are
X-ray of
right.
the chest. X-ray of the chest is most likely to confirm the cause of this patient respiratory distress. Most causes of acute dyspnea can be determined with careful history, physical exam, checks X-ray, ECG, um, blood gas analysis. In this case, the important history include dyspnea that began after admission and following transfusion of of the red blood cells. The physical exam discloses tachycardia, hypoxemia, crackles on pulmonary whatever exam, pulmonary auscultation. Given these findings, a check says will likely display pulmonary edema and vascular congestion associated with transfusion-induced hypervolemia, more commonly referred as transfusion-associated symptoms. In this syndrome, patients typically develop shortness of breath, tachycardia, PE within 6 hours of receiving significant volume. Oh, that's why you saw PE because it
Yes,
includes PE. Yeah, okay.
I
These
don't know that.
factors, oh, I didn't know that it also. So it's like a mix of like PE and other things. These factors for taco include renal dysfunction, heart disease, extreme age, hyperbuminemia, blah, 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 positive fluid balance prior to transfusion. Management includes discontinuing any transfusion, placing the patient in upright sitting position if tolerated, providing oxygen, giving diuretics. Occasionally, positive pressure ventilation may be required in severe cases. And you were confused with that. Okay, it's not ABG, often used to determine the cause of dyspnea as it provides information on oxygenation, ventilation, and respiration. However, in this case, the history of physical finding are suggestive of volume overloaded just and it's not you were ventilation. Okay, perfusion less scans are useful in the evaluation of PE in patients who cannot tolerate uh, the contrasted CT scan. They are also routinely ordered in the evaluation of pulmonary hypertension to assess for chronic pulmonary thromboembolic disease. However, they will not provide useful information on volume status on the acute setting. Okay, let me read that one.
Yes, yes.
The
Any option
pyridamol,
you would like.
okay, the pyridamol thallium scan is used to evaluate myocardial perfusion in non-exercise stress tests. Oh. The temporal association between the patient's symptoms and the recent transfusion. Okay, next. Next.
Yes, a 36-year-old woman is admitted to the hospital because of bleeding in the upper GI tract for 4 hours. 3 months ago, she was hospitalized for 20 days for treatment of necrotizing pancreatitis secondary to choledocholithiasis. 4 weeks ago, she was admitted for a similar episodes of bleeding. Her temperature is 37.3 degrees Celsius, pulse 110 per minute, blood pressure 110 by 70. The abdomen is soft with active bowel movements. Endoscopy shows bleeding from gastric varices. Endoscopy shows bleeding from gastric varices. The bleeding resolves with conservative treatment. Which of the following is the most likely cause of this patient's bleeding?
Hmm.
Is it hepatic vein thrombosis or is it cirrhosis?
Oh.
What I will think, like how they actually put this.
Splenic vein thrombosis, splenic vein,
There is
vein,
abdominal. Is there any abdominal pain?
abdominal, no. I mean, that, no. Fatty infiltration of the liver, maybe. It's not, I don't know why I don't think it's cirrhosis, because there is no, I
Cirrhosis
don't know.
has plenty of feature like esophageal varices, like bleeding.
But they say had gastric varices too. Gastric varices.
Oh,
Gastric
endoscopy.
varices.
Is the
Oh,
gastric varices is the esophageal varices both are
I
same
think
or
the
isn't it?
same.
I don't know
Oh,
actually.
oh, hmm.
I think that okay. Let's pick something and
Uh,
go for the
uh,
kill.
wait. Oh, okay. Wait. Feel like I can find. Ah, explaining thrombosis doesn't make sense, but the other ones don't make sense also. Okay, let's see.
What have you picked?
It's splenic vein thrombosis. Yeah, that's what I picked. The other ones don't make sense because if it was anything, the liver doesn't have any issue here because then they will what you said they will have a stomach issues. I
Like
mean
esophageal
abdominal pain.
issues, abdominal
Sorry.
ascites may be present. Yes, true.
Uh-huh. And abdominal pain and right upper quadrant, but they didn't. The only issue is the gastric varices, and there is something with the veins of the spleen and the. I don't remember some anatomy there. The patient's presentation is most likely caused by splenic vein thrombosis, resulting in variceal formation and subsequent upper GI bleeding. The abdominal organs drain venous blood via both a systemic route, draining directly into the inferior vena cava, and a portal route, draining into the hepatic portal vein, then passing through the liver before entering the IVC. In the portal system, the inferior mesenteric veins and the short gastric veins drain into the splenic vein. Oh, that is it. Okay. In the portal system, inferior mesenteric veins, short gastric vein go to the splenic vein, which then combines with the superior mesenteric vein to form the portal vein. Thrombosis in the portal system is in this region is a potential complication of pancreatitis due to perivenous inflammation, uh, as the splenic vein lies in anatomic proximity of the pancreas. Did not know that. Clinical manifestation depend on the location of the thrombus. For this patient, a thrombus in the splenic vein led to congestion in the draining gastric veins, yeah, and formation of gastric varices. In addition, the GI bleeding, in addition to GI bleeding, other complications of splenic vein thrombosis can include hypersplenism, thrombocytopenia, intestinal ischemia, and increased risk of abdominal infection. You got it?
No, can you explain?
No, there's like
It's like
it's like
a kind of anatomy.
an anatomy thing. Splenic vein and gastric varices. Okay, let's see. Maybe if we see it, it will make sense. Which one? They all look weird. This one don't even have the picture. Okay, maybe this one. Huh? Ugh, why is this so complicated? Okay, so this is the gastric varices. This is the splenic vein, and that's the thrombus. So it says that the short
The short gastric vein is the previous one.
this one,
No, in in near the spleen.
this one, I'm guessing.
The red one is the spleen, isn't it? And from spleen, there is this is I think that upper portion is a short gastric vein.
This one
Yes,
probably.
yes,
So
yes,
it drains here on the spleen, and then the spleen
yes,
one goes to the portal vein. You see, and
yeah.
then the inferior mesenteric also drains also in the spleen, and the
Splenic
spleen
vein.
goes. Yeah. So if there is a thrombus here, these ones will get dilated, and I guess if the thrombus is here, these ones and this one will also get dilated.
In
But you see
the
the superior one doesn't really drain into the spleen, so it will still be fine. And I don't know what is this one.
right gastric vein, right and left gastric vein.
Oh, okay, yeah. I know there is short, and then there is a I forgot.
No, short
But I think
gastric vein in the, I think that in the greater curvature.
the wait, the
Yes,
short are in the greater or
yes,
in the short?
shorter in
Oh.
the greater curvature. You can see another, like you search short gastric artery, then you will.
Like short gastric. Let's try this one. Okay, I think this one is better. Yeah, I guess short gastric is in the
From the
greater
spleen,
curve.
yes, yeah, nearby the great
It's
in the greater curvature.
in the greater curvature. And this one, I guess, is left gastric. I don't know. But yeah, then it goes to the spleen, and the spleen goes to the portal vein. And then the inferior mesenteric also goes to the spleen. And then the sigmoid goes to the inferior mesenteric. Okay, so the inferior mesenteric will be on the right side, I guess. What drains the right side? And this one, I wanted to know what drains the left side, but I cannot. Okay, the superior mesenteric, I guess it drains the left side. Okay.
Okay.
Okay. Next now. Okay. Next.
An 18-year-old man is brought to the emergency department. An 18-year-old man is brought to the emergency department 23 minutes after being involved 23 minutes after being involved in a motor vehicle collision in which he was thrown from vehicle into a tree. At the scene, his spine was immobilized with a cervical collar and backboard, and IV administration of the fluid was begun. On arrival, he is alert. His temperature is 35. Pulse is 125. Respiration 30 per minute. Palpable systolic blood pressure is 60 millimeter of mercury. Examination shows examination shows angulation of the mid-thoracic spine. He is unable to move his lower extremity. X-ray of the spine show compression, fracture, and angulation and obliteration of the spinal canal T7 to T8 after infusion of 3 liters of Ringer's solution over the course of 20 minutes. His pulse is 90. He remains hypotensive. Which of the following is the most likely cause of this patient's hypertension? Ready?
Yes. So it is decreased sympathetic tone. Neurogenic shock occurs in the setting of catastrophic CNS injury, such as cervical or thoracic spinal cord injury. This causes diminished or completely absent sympathetic output to the heart and vasculature, which subsequently results in hypotension secondary to decreased myocardial contractility, bradycardia, and arterial vasodilation. Treatment requires administration of isotonic fluids to attain resuscitation, although this may not be sufficient to overcome the widespread arteriolar vasodilation. Not C or D. Yeah. Hypothermia can be a feature of adrenal insufficiency. Adrenal insufficiency presents with hypotension, hypothermia, hypoglycemia, weakness, and variable metabolic acid-based derangement based on the level of calcification. This patient temperature is near normal. Hypothermia to cause profound hypotension is usually severe. It's not hypovolemia can lead to shock. Oh, wait, I'm not in the right.
Why it is not increased sympathetic? Sorry,
Wait,
increased
it's increased
capillary permeability.
um, increased capillary permeability is observed in anaphylactic and septic shock. Both forms of distributed shock also characterized by reduction in systemic vascular resistance. This reduction in systemic vascular resistance is secondary to IgA mediated histamine, cytokine release in anaphylactic shock, and cytokine or toxin mediated endothelial dysfunction in septic shock. Yeah. Hypovolemia can lead to shock secondary to reduction in intravascular volume, commonly related to hemorrhage or dehydration, which results in decreased cardiac preload, stroke volume, cardiac output. In turn, there is arterial vasoconstriction to increase systemic vascular resistance and attempt to maintain whatever. If progressive and severe compensation response fails, which leads to development of hypotension and inadequate organ perfusion.
Like,
Okay.
what makes
Mhm.
you think that it is neurogenic shock?
Because they kept emphasizing the TAT thing, cervical collar thing. They just kept emphasizing the fact mid thoracic spine angulation, whatever compression factor angulation again, obliteration of T4, blah blah blah. I don't know. The fact that they kept emphasizing that, I was like, okay, they're trying to tell me that the spinal cord is damaged somehow. And then it's what they say here: when cervical or thoracic is damaged, then the sympathetic tone that goes from the head to the whatever to the body is damaged, gets damaged. That's kind of how I don't know. That's kind of how I came out with. Makes a bit of sense.
Yes.
Okay. Okay. Oh, you can just remove the other one. We already know it's not this one. The myocardial contractibility.
No,
We
it
know it's
makes
not.
sense.
Yeah. Okay.
A 67-year-old man comes to the physician because of low back pain for a week. Because of low back pain for a week and urinary incontinence for 2 days. He is currently undergoing chemotherapy for squamous cell carcinoma of the lung with metastasis to the liver. Examination showed tenderness to palpation over the lumbar spine and decreased sensation below the umbilicus. Rectal examination shows decreased sphincter tone. The prostate is diffusely enlarged. Which of the following is the most appropriate next step in the diagnosis?
Ready?
Yes. Is it Cauda-Equina syndrome like that?
You think so? Yeah, it can be that. Yeah. 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 Patient with a diffusely enlarged prostate likely has prostate cancer. Oh, you don't see that one. Prostate cancer, which often metastasizes to lumbar spine. An occasional declaring presentation of metastatic prostate cancer is low back pain caused by metastasis of the lumbar spine. MRI of the spine is indicated for evaluation of acute onset neurologic deterioration. Cauda-Equina syndrome occurs from acute compression of the cauda-equina nerve roots in the lumbosacral spinal canal, most commonly from disc herniation or traumatic pathologic vertebral fiber. This results in bilateral lower extremity weakness, loss of deep tendon reflex, bowel and bladder dysfunction, and subtle anesthesia. Emergent MRI of lumbosacral spine is indicated to investigate cause of cardiac syndrome to determine the necessity for surgery. It's not measurement of PSA is used as a tumor marker to monitor prostate cancer. While this patient likely has prostate cancer that has metastasized to bone, this patient's signs and symptoms of cardio as an emergency, and MRI should be the next step diagnostic. Next.
A 25-year a 25-year-old woman is brought to the emergency department on on a backboard with her neck and head restrained after a motor vehicle collision. She was not wearing a seatbelt. She is awake but confused and has no memory of the crash. Examination shows a contusion on the right side of the head and a clear fluid draining from the right ear. Which of the following is the most likely explanation of this finding?
No. Mm, oh, sucks. No, that's not gonna do this. Ready?
Yes.
With cranial fracture that has disrupted the meninges, basilar skull fractures typically occur after high impact blunt head injuries, such as this patient after a motor vehicle in which she was not wearing a seatbelt. A basilar skull fracture is defined as fracture involving at least one of the bones that make up the base of the skull, like the cribriform plate, orbital plate, and frontal bone, orbital plate of the frontal bone, sphenoid bone, occipital bone, petrous or squamous portion of the temporal bone. In this patient, with the contusion of the right side of the head and clear fluid draining from the right ear, fracture of the temporal bone is likely. Mm. Patients with basilar skull fractures can present with hemotympanum, uh, CSF fluid, or bloody otorrhea or anuria, retroauricular and periorbital ecchymosis, and cranial nerve palsy. CSF leaks occur due to meningeal tear of the dura, creating a communication that allows cerebrospinal fluid to flow out of the middle ear or nose. It's not comminuted skull fracture causing lymphatic disruption of the ear in the ear can result in perilymphatic fistula, which is a fistula between the fluid filled inner ear and the middle ear. Perilymphatic fistula can cause symptoms such as sensation of ear fullness, hearing loss, setting, blah, blah, blah. And it's not, what was I confused about? E, maybe. Zygomatic fracture will not explain the presence of clear fluid draining from the right ear, which is likely due to CSF leak. Linear skull fractures often are simple close and have minimal clinical significance. The presence of external CSF fluid drainage is basilar skull fracture. Okay, next. Hmm.
What is your diagnosis?
Hmm.
Is it
Melanoma.
melanoma? Isn't it?
I
Let's
think I'll take it.
let's see.
It is melanoma, malignant melanoma, likely to be present when a lesion demonstrates asymmetry, irregular borders, variable coloration, diameter more than 6 mm, and rapid evolution in characteristics. It's neoplasm melanocyte, which contain pigments in whatever. Histologically, it may appear as dendritic cell containing pigment granules with high nuclear blah blah blah, mitotic figures, and increased size compared to normal melanocyte. Malignant melanoma can rapidly invade and metastasize, which carries poor prognosis when diagnosed late. Subtypes include superficial, spreading, nodular, lenticular, whatever, whatever. Any lesion with features suggested might should be surgically excised with negative margin and examined for depth and dermal invasion. Next.
A 65-year-old man comes to follow-up examination a 1 week after excision of a small raised lesion with a pearly margin from the lateral left nares. The pathology confirmed BCC with the tumor extending to the resection margin in one section. Examination shows well-healed incision. Which of the following is the most appropriate next step in the management?
Ready? Oh,
Yes.
wait, what happened? I didn't pick one for this one. Never mind. This and then this. Okay. So it is excision of the excision site. BCC is the most common form of skin cancer derived from the basal cells of the epidermis. Primary risk factor for developing BCC is UV light exposure, age, fair skin, family history. BCC typically presents pink pearly papules or nodules with raw borders and central ulceration. It's an exposed area of head and neck. Subtypes of BCC includes those that are less invasive, such as superficial and nodular, and those that are more invasive, such as morphiform and infiltrative. In all subtypes, the risk of metastasis is low, though the tumor can invade locally and cause significant tissue damage. Biopsy may be performed, variety of technique, excisional, shave and punch biopsy. Treatment of BCC requires complete surgical removal, either by excision or most surgery. In this case, in the case of incomplete excision or excision with negative biopsy margins is indicated to reduce the risk of metastasis. Next.
A 57-year-old man is brought to the emergency department 30 minutes after sustaining burns over 40% of his total body surface area in a house fire. His pulse is 110 per minute, respiration 22 per minute, blood pressure 120/70. The burned surface is anesthetic and covered with a thick firm brownish eschar with a thick firm brownish eschar. Thrombosed vessels are visible through the burned surface over the next 24 hours. Which of the following is the most urgent priority in the management for this patient?
Hmm.
Ready?
No. How did you find it so quick? Okay. Ready. Let's see. Um, Probably not that. Oh, is that? IV fluid resuscitation is the most urgent priority in management of this patient with severe full thickness burn, which is often classified as burn involving more than 20% of the total body surface in adults. Severe burns can result in more numerous complications, including compartment syndrome, secondary to scar formation, AKI, coagulopathy infection, but the priority within the first 24 hours is to replace the fluid loss that occurred during and immediately after the burn. The Parkland formula, which is no, 50% of the total fluid requirements are given in the first 8 hours after burn and whatever. Ongoing fluid resuscitation following the first 24 hours is usually type of blah blah blah. Subsequent management should focus on providing temporary coverage of the burn areas and adequate nutrition, managing pain, and treating preventing complications such as compartment syndrome and infection. It's not hyperbaric oxygen um, therapy has not been shown to improve outcome of burn victims in acute setting, although it is sometimes used later in the course of compromised skin graft. The most common use of hyperbaric oxygen therapy is for carbon monoxide poisoning and dive-related injuries such as decompression sickness. Administration of tetanus vaccine is important for a patient with any burn that is more than superficial. If the tetanus vaccine status needs to be updated, but this is less critical than resuscitation. Broad spectrum antibiotics as a prophylactic measure is not indicated in patients with severe burn. Although many of these patients may develop infection during the treatment and recovery, the use of broad spectrum antibiotics in the absence of suspected or proven infection does not improve the outcome. And then last one, excision and grafting may be performed within the first like 1 day to 3 days using a variety of techniques, but it's not the initial priority in patients with severe burn. Okay. Next.
Yes. Okay. What is your diagnosis?
Oh, I don't know.
Fluid collection, isn't it? Isn't it bulla,
Okay.
pemphigus vulgaris, or pemphigoid? Isn't it like that? I'm just asking you.
Um, I I cannot know from this image. I don't think so.
Okay. I will read the question, don't worry, but
Okay, I was saying I do not know.
give something, give an observation. What have you thought?
Uh, yeah, I guess Bula. Yes.
Yes.
Okay.
Like if you see any picture, you without reading the question, you should think about a differential. It will help you. Okay, I'm talking too much. A
Go.
47-year-old woman, sorry, why I say always woman, a 47-year-old man comes to the emergency department 3 days after he sustained a painful injury to his right knee with a fall. He explains that he thought he had only scraped his knee, but the wound has been getting progressively worse. He has 20-year history of type 2 diabetes, malnutrition, insulin, tetanus vaccination was 3 years ago, temperature 101, pulse 100 per minute, regular respiration 12 per minute, blood pressure 155 by 60. A photograph of the right knee shown palpation of the affected knee produce a pain and crepitation. An X-ray of the knee show right knee shows gas in the soft tissue, no abnormality. Analgesic beacon, urgent surgical development is planned. Which of the following is the most relevant next step? Management.
Ready?
His most tetanus vaccination given 3 years ago. Do we need tetanus toxoid now?
I don't think so. I think it was
I
either five or I
sorry.
don't think
Yes,
so.
it is either five. Is it antibiotic to give now?
I think it's antibiotic because he has fever. And
Yes.
then all the others don't make sense. I don't know what silver sulfide. I don't know what that's for.
Silver sulfur diazine for like burn.
For burn, okay, so it's not that. MRI of the knee don't make sense. Steroid don't make sense. Hyperbaric oxygen we just read is for carbon monoxide and
Because I have a
sequestration.
history of burn also, so I know that.
Oh,
Okay.
so that's why you okay. Let's see. It's antibiotic therapy. No, sometimes that's good if you're going to like it because it's
I
something
have
if you
I
have
have
it, you
plenty of
know.
experience. Like I
Yeah,
have
if you have it, you know.
plenty of physical problems.
Please.
Okay.
Antibiotic therapy is the most appropriate next step uh, in the management of this patient with evidence of necrotizing fasciitis and infection typically caused by strep pyogeny or a mixture of aerobic and anaerobic. Those singular organisms like Clostridium perfringens and Staph aureus are sometimes encountered. Necrotizing fasciitis refers to infection spreading around the deep fascia pain that presents with acute onset of pain out of proportion to exam findings. Redness and paresthesia, which progresses to anesthesia, typically occurring at the site of prior trauma or surgery. These factors, trauma, underlying systemic illness such as diabetes, liver failure, renal failure, as the bacterial infection spreads along the deep fascial pain, bulla with or without crepitus may develop. The extent of infection is often difficult to assess by exam alone, although X-ray may disclose the presence of gas in the tissues. Treatment requires broad spectrum antibiotic fluid and emergent debridement of the often multiple sequential debridements are required. Empiric antibiotics usually include vancomycin, or I guess that's the Staph aureus, and piperacillin tazobactam to for broad coverage, in addition to clindamycin to inhibit toxin production in cases of Clostridium perfringens strep pyogenes. Okay.
Okay. We should stop for today.
Okay.